I get to talk about scleroderma in your kidneys. So I think probably there's a big elephant in the room other than my belly that's on me, but that there's one big manifestation in the kidneys that occurs with scleroderma, but we're also going to touch on some other things that's actually much more common and probably deserves a little bit of attention and things that we need to pay attention to. But at least the good news is that the majority of it can be well managed. So again, thank you for having me. Just a quick outline, and I'll try not to get into too much granularity when we're talking about some of these things. I put some pictures up that probably are a little bit too much, and we'll kind of go through them quickly, but it's more to show you the complexity of the disease, and then we'll kind of go past and talk about some of the more things that are important that you guys probably care about. But we're going to talk about how does the scleroderma affect my kidney. So all of the different manifestations, and we're going to touch on some briefly, and then we'll talk about the renal crisis closer to the end. Who is at risk for scleroderma renal crisis? That is what, that's what SRC is going to stand for. What does SRC look like? Treatment, survival, dialysis, transplant, if we should get transplanted, and then maintenance and prevention overall. So I think probably before we go further, and you guys may know this already, so my apologies if this is too basic, but I think that just briefly discussing what our kidney does to us is important. And quickly, the anatomy. I'm always surprised that sometimes people don't know what the anatomy is, and it's important to know that these are our blood vessels that supplies our kidney. And our kidney, if you see over here, this is a cross section, but it's doing a lot of things in there. So this is what it looks like, and there's all of this activity happening. But essentially it's making urine's going into here, and then it's going to drain down into our bladder, and then we pee it out. But these are the big things that our kidney is doing for us, and sometimes we don't realize how important it is. But it filters waste, and then we excrete it as urine. But it is mainly one of the biggest controllers of our blood pressure, and it's incredibly complex. But that's why oftentimes we do a lot of the blood pressure management for our kidney patients over cardiologists. But also you'll see that this is one of the reasons why scleroderma renal crisis really occurs in our kidneys, because of our kidneys and its dysfunction. And then last, water and salt regulation is really important. So our volume status. I mean, if you're really dehydrated or something in general, if your kidney is working well, it's going to maintain your body hemostasis really well. Any questions with that briefly? That'll make quite a bit of sense. I can move forward. So the types of kidney injury and systemic scleroderma, I'm going to also be referring to that as SSC, just because it's a big word, two big words to spell out. We've got the primary cause, so it's what's happening within the kidneys. Scleroderma renal crisis, which we'll touch base in a little bit. We have some of our mixed connective tissue diseases, like that go along with systemic lupus erythematosus. I'm going to briefly touch base on that. And then we've got our secondary causes, and by and large, our secondary causes, meaning other things, either medications or some of our extra-renal manifestations, or the other things that are occurring in our body secondary to scleroderma, are what are affecting our kidney. And by and large, these are really what are affecting our kidney, and generally the good news is they can be benign, reasonably benign, and well managed if we catch them. And I'm going to touch base on these in just a second, but a lot of medications can affect them. Some of them are sort of historical medications that were utilized in scleroderma in the past. Others are really common ones that everybody uses, and they're really important for managing your symptoms. And then, like I said, some of the other manifestations, chronic hypertension, heart failure, the pulmonary hypertension that goes along with the interstitial lung disease. If you have problems with your GI tract and you're not absorbing well, you have diarrhea, you're not able to stay hydrated. These are some of the other causes or things that can affect your kidney function. So very briefly, secondary causes, as I was referring to, is the picture of heart failure. Heart failure can be a manifestation of a lot of the issues with scleroderma. This is a picture, I'm sure you've seen this, Dr. Fisher's probably put this up. But you can have heart failure from interstitial lung disease, pulmonary hypertension, which can all lead to kidney dysfunction. High blood pressure, long-standing, can also affect your kidneys. This is supposed to be my picture of dehydration. We're supposed to be 60% water in our body, but that can get depleted, and if we're not able to perfuse our kidneys because we're dehydrated, we're not going to be able to actually get the best kidney function possible. And then this is representing all of the medications that we're taking just to help treat a lot of our symptoms that we're dealing with from a scleroderma standpoint. So common medications, proton pump inhibitors is becoming one of these new ones that's emerging. Everybody's on like Prilosec, omeprazole, all of these medicines to help with their reflux and some of their GI symptoms. It's still pretty rare, but it can occur. And so it's something that we pay attention to, and we ask all of our doctors that are managing and surveilling you all to pay attention if they start to see changes in your creatinine, and that's the number that a value or a lab value that we utilize to help monitor your kidney function. NSAIDs, you've probably heard that term before. It's a catch-all. Non-steroidal anti-inflammatories, ibuprofen, naproxen, Aleve, Motrin, Advil. This chronic pain, we all need this for chronic pain. It's incredibly useful. It can help a lot of our symptoms, but in excess can also do us harm. So I'm not saying we don't use these medicines. I'm saying that we pay attention to whether or not we do have some decline in our kidney function. And then how do we move forward from that? And even then, we won't necessarily say don't use them, but it's really being able to recognize that they can cause it and being aware of it. And then last, diuretics, volume overload, also really important in terms of how we manage our swelling. If we've got that problem, particularly with pulmonary hypertension, heart failure, things like that, they're really important also to manage our symptoms. But we can't overdo it, and if we overdo it and we volume deplete ourselves by making ourselves pee too much, we can do some harm to our kidneys. So very briefly, this is a picture you guys do not need to know. I just think it's pretty because I'm a kidney dork. But this is a this is a biopsy of somebody who's got a very specific disease. But the overlap syndromes, mixed connective tissue disease, lupus, I don't know if any of you guys have that particularly, but by and large, the classic lupus kidney manifestations you can have, it's actually surprisingly more or less protective, but you can get it. But 25% of patients will still develop some form of kidney involvement. I'm not going to go in depth with what the kidney involvement is because, to be honest, it's a little more complex. But membranous nephropathy is probably the most common, still pretty rare. And then you can get a collapsing FSGS. These are all manifestations that occur microscopically within our filtration system in our kidney. And then the scleroderma renal crisis still can occur as well. So those are manifestations that still occur in our kidneys. Does anybody want me to pause for any questions right now?
What's FSG?
It's called focal segmental glomerular sclerosis. And it's a filtration process. It's a big word, right? It's hard for me to say it. But it's a filtration process that happens. This is very microscopic within our kidney, and this is where exchange of sodium and potassium occurs, and a bunch of other things. And if we get a bunch of protein that's actually going through that, you're going to waste a lot of protein into your urine, and then you get this really, really, really swollen body. We call it a nephrotic range, but it's basically you're wasting all your protein. And that happens with both of these. This is more rapid, this is more slow. It's a much slower process, but it's something that if your physician, whoever's following you, notices it, then they're going to probably refer you to us. This one has a pretty good treatment. This one's a little more challenging. This one's incredibly rare. Incredibly rare. Okay?
Thank you.
Okay, anybody else have questions with that before I move forward? No? Okay. So I just wanted to highlight, if we were to take everybody with scleroderma and we were to biopsy their kidneys, which we don't really want to do, we would probably find some changes microscopically within your kidney in 60-80% of them. That doesn't mean that you all are going to be, suffering from kidney disease. It just means that if we were to take a biopsy, we'd see changes. Only 50% of them do we actually see clinical manifestations of them, and whether those are clinically relevant is also hard to know. Probably the majority of them are not. Either we'll see somebody who's got a little bit of protein in their urine, somebody who's got a slightly elevated creatinine based than normal. Is it going to affect you long term? Probably not. Is it going to make us pay more attention and to do more, pay attention to your medications, make sure we're monitoring your volume status, all of those things? Yes. And it might make you have to follow a nephrologist as well. Dr. Aria and I, before I actually took a position at the VA, shared a number of patients together. For that reason, and I actually did not yet have one of his that has scleroderma renal crisis. That being said, the dreaded one is the scleroderma renal crisis because it does have a much higher morbidity and mortality. 5 to 20% of patients, specifically with diffuse cutaneous scleroderma, are the ones that develop it. So not nearly as many, but it's the one that we pay the most attention to because it can do the most harm. So that's where we're going to move on to from here. Once again, I'm going to try not to go into too much granularity, but in terms of what does scleroderma renal crisis, not to call anybody out, so nobody has to raise their arm if they want to, but has anybody experienced that that's here? Pretty big deal. Yeah. Pardon? No, anytime. Yeah. It's, to be perfectly honest, it's a really big deal and it can affect a lot of things in our body. And it can be, you may end up in the hospital or it may be caught pretty early and you won't need to, but it's a big deal. But from the standpoint of knowing what it looks like, you get acute onset of kidney failure. It's pretty rapid. You get really, really, really high blood pressure. It's not, like the 150s or something. I mean, it's really up there. It's 190s, 200s, really high. And then you get a lot of manifestations that are related to this high blood pressure. So this is, I'm going to go down to here, associated symptoms. You can get heart failure. You can get a collection of fluid around the heart. You can get flash pulmonary edema, so rapid collection of fluid in your lungs. So these are all symptoms. Hopefully you guys don't really experience them. You can get one or the other, but you pay attention to all of them. You get a headache, and that's also related to that blurred vision. That's because you get these sort of changes. This is the back of the eye. You're not supposed to have these. These are sort of called cotton wool spots, and you just get reduced perfusion because the blood pressure is so high. You can be confused. You can have seizures. These are all related to basically having such poorly controlled blood pressure. I have this picture here. I don't expect you to remember this either, but it's basically you get microangiopathic hemolytic anemia. That's because of the changes that happen in our tiny little blood vessels that are supplying our tissues. And if you see, these are red blood cells. They're supposed to be nice and circular. They become fragmented. And then you also get decreased platelets. And it just happens to be that these vessels get really small, and you get these collections of sort of fibrin across it, and they kind of slice them in half as they're going through. And it's based on just this really high blood pressure that's changing the architecture of our vasculature. I'm not going to go through this in depth, but I want you to know that this is essentially what's happening, and you see all these arrows that are pointing in both directions. And you see there's a lot of fibrosis and a lot of increased blood pressure and decreased blood flow to the kidney, and they all sort of go back and forth and point in every which way, and they're causing one another. So the most important thing is you really do need to stop that cycle by bringing down the blood pressure. And then I told you kind of exactly what we were talking about. I'm going to tell you these are tiny little blood vessels right here, and all of this is changing of the architecture. It's not supposed to be so thick, and you should be able to see a much larger hole, and so you get these tiny, tiny holes that are going to slice these red blood cells. You're going to get anemic or a low red blood cell count, and you're going to get a low platelet count, oftentimes, not all the time. But you also see that the kidney, you guys probably won't see it, but the kidney architecture is starting to change too. And once you affect the kidney architecture, you don't want to get it to the point where there's no return. So, very briefly before we go to interventions, am I at risk for scleroderma? Or, scleroderma renal crisis? diffuse skin involvement in general are the people who are at most risk. It can sometimes be the presenting symptom. And so you present with the scleroderma renal crisis, and then we discover that you actually have early on, the early signs of scleroderma. It's usually early on within the disease process as well, 3 to 5 years. You're at increased risk if you have rapid progression of skin thickening. One of the managements or treatments, at least for some people, is glucocorticoid use. So we try and minimize this as much as possible, because for some reason, and I think it's not well understood, maybe Dr. Fisher knows, but it can increase your risk of developing it. So if it's necessary, try and limit the dose and the duration. Very specific autoantibodies, anti-RNA polymerase, have been shown to put us at increased risk. I don't know if you guys know which antibodies are positive in your cells. I'm sure your doctor has told you. But this can be useful in terms of letting you know and how closely you need to be surveilled. People with a tendon friction rub, people with joint contractures and arthralgias. And then there's sort of this cyclosporin use that I'm not going to go into much, but it's one of our immunosuppressive drugs that can also increase it. And that's because it can also cause this vasoconstriction of the vasculature, so narrowing of the vessels, of the tiny vessels, specifically in the kidney. So I think we briefly touched on this. Signs that I have scleroderma renal crisis: reduced urine output. Now, this to me is a double-edged sword, because if your kidneys aren't working as well for any reason, or if you're dehydrated, or, that's what your kidney does, right? You're dehydrated, your kidney's like, I'm going to hang on to as much water as possible, so your urine output's going to drop off a little bit. But on top of it, really high blood pressures. If you have shortness of breath, a change in your symptoms from a lung standpoint, fatigue, new onset chest pain, swelling in your lower extremities, that's a reason for you to really seek help and say, hey, what the heck is going on? I know that a lot of us, have some of those manifestations anyways because of their lung problems, but if it's new onset, pay attention to that. Headache, as we said, blurred vision because of those findings we find in the back of the eye, confusion, seizures we're going to seek help anyways if somebody seizes that. So treatment, untreated progression is rather rapid, and I'm going to show you an image coming up here. But with 1 to 2 months, you will go into kidney failure. So treatment is incredibly paramount. In general, because of some of the other symptoms, you're going to be seeking help. You probably, by and large, will be getting treatment no matter what. But it's blood pressure control, and very specifically, it's an agent called an angiotensin converting enzyme inhibitor, probably more familiar to you all as captopril, lisinopril, enalapril. Some of you may be on it. But that is the medication that is absolutely necessary and will keep you on that lifelong, even if your blood pressure is controlled after this, or even after you get a transplant. I'm going to stop here. Does anybody have any questions so far? Yes?
Question, you talked about contractures, and there was another word there.
Oh, yes. Joint contracture. So, yes, thank you. Joint pain is arthralgias. I apologize. And joint contractures are actually, you've got so much, your skin is thick enough.
I understand the contractures. I just didn't understand what that other word was.
Does everybody else understand joint contractures? Yes. Okay.
Thank you.
You're welcome. Okay. So this is the good news. I can tell you what the bad news was in 1972. You can see up here, this is cause of death related to scleroderma. And back in 1972, scleroderma renal crisis was #1. And by and large, it was doubled compared to the rest of them. After the advent of our ACE inhibitors, so lisinopril, captopril, enalapril, those blood pressure managements, and those specifically, we have now come down in time to this being the cause, and this is up to 2001. So that's pretty phenomenal. Thankfully, we've got that medicine now. And that's really the mainstay of treatment, and it's the best treatment that we have for it. And then the rest of it is essentially preventative. So this is going into recovery after a scleroderma renal crisis. It's not uncommon to be dialysis, to require dialysis at some point during this. But what you'll see is that at about 2 years or 3 years, 50% of cases are off dialysis and still alive. But recovery can be up to 2 years after the injury. So oftentimes we'll make a decision if we transplant somebody based on giving them enough time to recover and come off dialysis. You can actually see lab evidence of kidney recovery up to about 4 years. So this is a value that we use is called creatinine clearance, but it's measuring someone's kidney function. So I think this is not as important for you guys as it is for me because I pay attention to how someone's kidney recovers and to what degree, but really you can see quite a bit of recovery, so you have to give the kidneys time to remodel after they've had such a big injury. So people may end up on dialysis for a prolonged period of time. And I'll show you just coming up here shortly how many people end up on what. So this is overall survival. So after 1 year, if you don't require dialysis, your 1 year survival is 81%. That's not as good as we'd like it to be, but it's better than it used to be. And that's, of course, getting appropriate treatment. 71% at 3 years, 47% at 10 years. And then this is also just, so this is reflecting, this overall is reflecting this line. And then 42% up on long-term dialysis here. 24% end up on just temporary dialysis and will come off, but it may take up to 2 years. And then 34% will not require dialysis at all. Do you mind if I ask you, did you require dialysis? You did? How long did it take you to come off?
2 years.
Okay, so you got transplanted. So I think this is another thing that's important to know, and this is why we absolutely do recommend dialysis, is that 2 year survival, oh, excuse me, this is just overall, long-term dialysis compared to non-scleroderma patients. We see that people just staying on dialysis and don't get transplanted, there's a much lower survival, and probably part of that is related to the actual disease that we have. But we do know that this is a good reason for us to transplant people, even if outcomes aren't quite as good as we've wished or as we would hope that they would be. So am I a transplant candidate? As long as your other disease manifestations don't prevent you from getting a transplant, absolutely. And we do recommend that you go get a transplant. It's a pretty big evaluation to see if you're a transplant candidate, and we leave that up to the transplant kidney doctors to decide if you are. But the hope is that your lung function is good enough and that your overall other manifestations won't prevent you from getting a transplant. So our transplanted kidney, and this is actually not, this is the kidney graft, like the allograft that's been put in you. This is the survival of that. And it's a bit variable, but we do know that it's not as good as in someone who doesn't have scleroderma, but it's worth it. So at 1 year, 68 to 79% of the graft will survive, 60 to 70% in 3 years, and 57% in 5 years, which is worth it. Would you say it's worth it? Absolutely.
We say it's worth it. We love her.
What's that?
If we say it's worth it, we love her.
Okay. And so let's say you actually decide, you're debating if you want to have a transplant or not. This also is just another argument, and you can see up here on this, but 90% survival of 1 year if you get a transplant versus 80 if you stay on dialysis. 81% in 3 years and 55% if you stay on dialysis. I don't think I really have to convince you guys of that, but I think it's important data, at least when early on when they were deciding if we should be trying to put kidneys in patients who may not have may not have as high of a survival rate as patients without scleroderma, but it's still absolutely worthwhile, and we should put kidneys in these people. And then the reason that we wait this long is I already put this up just once. But up to 18 months, usually they will wait 18 months. I think there are some transplant docs that will do it as early as 6 months, but it's because people can come off dialysis, so we give them up an opportunity to recover and come off dialysis and not get a transplanted kidney, and that's because you're put on the first year after transplant, there's high risk of death with all comers, even more so in the scleroderma patient. So if you can recover to the point where you don't require the immunosuppression meds and you don't require a transplant, absolutely we want to give you the opportunity to do that. And so that can be up to 3 years. We've cut it down to 18 months. And that's by and large, that's usually the date, the time frame that they wait to see if you're going to have kidney recovery. Okay, so good news. Recurrence of scleroderma renal crisis after transplant is actually pretty low. They say less than 5. I've actually seen reported even less than 3%. It's usually early on, 1 to 2 years post-transplant, even more so like very, very early on. It's often difficult to tell the difference between scleroderma renal crisis and acute rejection, and it may be preceded by some of the more classic presentations of diffuse skin, progressive skin thickening. New onset anemia might just be a sign of it because of those vascular changes I talked about. And then cardiac complications, CHF is congestive heart failure, or collection of fluid around the heart, which is pericardial effusion. I'm going to pause here. Does anybody have questions yet? Yes, sir.
Yeah, hopefully I can state this in a better sense. You intimated that if you had renal crisis, and it's better to have a transplant than dialysis. The question I have is, what happens if you had neither, but had the renal crisis, and you're currently just being treated with medication? Does that mean the survival rate is even lower than the first two?
Okay. So let me see if I understand your question correctly. The question is, if you don't require dialysis, and you're just getting treated with an ACE inhibitor like lisinopril, captopril, what is your survival rate? And let me go back to that. I have that slide, but and it's this slide here, and I want to point out that this is not significant, but essentially, if you don't require dialysis, you don't require transplant, probably your survival rate is better if you're just being managed by medicine. Okay. Certainly if you require dialysis, absolutely not. If you get a transplant, there is risk to transplant. There's risk to loss of the allograft, but also you're on a lot of immunosuppression meds. There are immunosuppression meds already involved in scleroderma, but it's even more so. And so risk of infection and things like that do go up. So in general, if you don't require dialysis, that's a plus. Okay, so long-term management is we're going to continue that ACE inhibitor. And even if your blood pressure is controlled, you're going to be on some dose, whatever dose your body will tolerate. We don't want to drop your blood pressure so low that you can't function, but you want to be on some degree of that medicine throughout the rest of your life, even if you get a transplant, even if you're on dialysis. You want to avoid as best as possible the medications that could harm your kidney. So from that standpoint, I would say limit your anti-inflammatory medicine use like NSAIDs, ibuprofen, Aleve. Now, if there is something to do with you can't, quality of life, we'll say use it sparingly. Post-transplant, we'll minimize corticosteroid use and some of the other medicines that are utilized. So we would choose different medicines from an immunosuppressive management standpoint. I'm going to face this way because if I turn my head the wrong way, you can't hear me. Home blood pressure monitoring, that can be really useful. So getting you guys involved in, number one, paying attention to symptoms, and also being aware of how well your blood pressure is managed. And so communicating with your physician if you feel like it's not well managed. And then frequent follow-up with your rheumatologist and your nephrologist and even your primary care to make sure that things are staying stable. And then how can my doctor and I prevent scleroderma renal crisis? We can't necessarily prevent it. We can do everything we can to at least pay attention, be aware. There's been some studies looking at starting ACE inhibitors early, and actually they think that that might mask blood pressure, a rise in the blood pressure. So there's no evidence to start the medicine early. We only start it once we've identified it as a potential cause for kidney harm. And then regular visits with your doc. If you're not seeing a nephrologist yet, your primary care doc, your rheumatologist. Again, home blood pressure management can be useful, and then awareness of the symptoms so you can catch it early. And that's what I have for you today. Do you guys have questions? I think I went through that quickly. I apologize. Yes.
I'm hoping my family member never has to get a transplant, but are family members good donors, I guess is one question.
Absolutely. Family members usually are the best donors,
Okay.
as long as you are considered. I mean, you'll be tested to see if you're a match. Age also matters, but sometimes we try and match ages a little bit more, as opposed to giving a really young kidney to an older person, and that would be a discussion to have with the transplant doc.
How are kidney transplants going these days? Are they pretty, is it easy to get them, or is it really difficult?
To get a donor kidney? So if you don't have your own donor and you're waiting, so this would be a deceased donor, it's actually better than it used to be because they have all these different paired exchanges and things that are going on. Somebody can go on the list. If you were a scleroderma patient and you went on the list, you probably have a similar wait time as a normal person, which is still 5 to 6 years. Can be lower, can be higher depending on where you live. But in general, they've done a whole bunch of things recently that have improved our ability and improved our access to donor kidneys. Yeah. Other questions? Yes, sir.
You mentioned Prozac, which is harmful to kidneys. I'm taking Prozac, and is that something I should stop taking? And I know you said that sometimes, but is this something that can help the cause? Or is this something that's more after the fact that your kidneys won't like it after you have renal crisis?
So it can cause a very specific manifestation in the kidney that's unrelated to scleroderma. It's actually still pretty rare. So I would say, no, I would not stop it. I would say if it's helping manage some of your symptoms, absolutely keep going. It is just important to be aware, and even more so for your doctors who are managing you, that if they notice that your kidney function is declining, being aware of what medicines you're on that could be attributed to it. So it's called an acute interstitial nephritis that it can cause, and it's emerging as something that us nephrologists are recognizing, but it's just recognizing that it is one of the many medications that can do harm. But like I said, it's still very rare. A high percentage of the population is on a PPI, Prilosec, omeprazole, is the generic, pantoprazole, esomeprazole, all of those, and they're really good at managing those reflux type symptoms. So I would say absolutely keep it going. It's just more being aware that it can cause something with your kidneys. I wouldn't, even if you had a scleroderma renal crisis, I wouldn't necessarily recommend stopping it either. But if there's something else going on that we're having a hard time identifying a cause, that would come up and that would pop up as a little bubble that I was thinking about.
Thank you.
Yes,
First of all, thank you. It was a great talk. And it's always tough to talk about scary stuff.
yeah.
You know, so I just want to highlight that for reasons that are not so clear, we know more about who's at risk for this complication of scleroderma renal crisis than we know about almost anything else in scleroderma. So you highlighted, for example, joint contractures, which can be seen, but we really think about it like you said, that early first several years, a specific antibody rapid skin involvement.
Mhm.
So in some ways, we would reassure a lot of our scleroderma patients who are
Thank
not really at risk for renal crisis, because we know their antibody, we know what type of disease they've had, we know how long they've had it, and yet we know in whom to really put a heightened surveillance program in place. And for you all, this might be an opportunity for you to ask your scleroderma doc, hey, you know, I heard about scleroderma renal crisis. Where am I at risk? You know, am I on a low risk or am I on a higher risk? And if I'm at higher risk, how can we be more vigilant about keeping an eye out for it?
Right.
So just thank you for, again, tackling a tough topic.
Any other questions? I would definitely say we don't get to see, as nephrologists, that many scleroderma patients because it's not that common.